I grew up on a dairy farm, so the agricultural component of the antibiotic resistance problem and the antibiotic use problem is something that is very near and dear to my heart, although I am going to be talking today about improving antibiotic use in humans in the community. I also want to mention that we're working across the spectrum of healthcare on inpatient work, and you'll hear from Arjun about that in just a few minutes, as well as long-term care. But this talk will take a deeper dive into what Beth started to talk about related to stewardship in the community setting. And the Get Smart program has actually quite a long history. We launched the national campaign for appropriate antibiotic use in the community in 1995. And that very long and awkward name was fortunately changed in 2003 to Get Smart, Know When Antibiotics Work. And that actually coincided with a very large media launch. And I just want to mention that we didn't just pick that name out of the air. We actually decided that it was very important to test both the messaging that we were using to target both providers and patients with those populations. So that name came from a lot of focus testing with both providers and patients. And we've had a historical focus on acute respiratory tract infections, and the reason for that is that's because where the most inappropriate antibiotic use occurs in the community. And so we'll talk about how that's been really our focus in ambulatory care to improve antibiotic use for those specific conditions. And our program aims to reduce the spread of antibiotic resistance by promoting provider adherence to prescribing guidelines. We work on decreasing demand for antibiotics among healthy adults and parents of young children. And I think this is really important because actually that demand piece drives a lot of inappropriate prescribing by providers. And then finally, if an antibiotic is prescribed, we want to make sure it's used correctly. So we work with providers and pharmacists to actually educate patients about adherence to prescribed antibiotics. And I just am putting these materials up here for a moment for you to take a look and see that there's actually quite a bit of tailoring of our materials and messages for different audiences. And just to make it clear, the materials on the far right and the far left are for general public. All of these are general public audiences and parent-related materials, but you'll see that we have some Spanish materials there as well. And we used Be Informed for the Spanish-speaking population because that's what resonated with them. And we used Be Smart with the Native American population because that's what resonated with them. So I think it's the important point is here that we have to work very, very closely with our target audiences to identify what works best for them in terms of messaging. I also wanted to mention that we've developed a number of provider tools, and this is just a few examples here, but we've worked on treatment guidelines and academic detailing sheets, which distill our treatment guidelines in easy-to-use form for our providers, continuing education resources, medical school curriculum. We have a symptomatic prescribing pad that helps providers provide alternatives to antibiotics when antibiotics are not needed. So this is just one example of a tool. And then we have a lot of information on our website about antibiotic stewardship interventions that can be done in a practice. And Beth actually mentioned this, but I'll go maybe into a little bit more detail. The purpose of our Get Smart About Antibiotics Week is really to increase the number of actually actively engaged program partners in the promotion of Get Smart messages to target audiences. And this is really an effort to get the messages out to the audiences we're trying to reach, but we can't do that alone. We really need to work with a number of different partners in order to do that. And this has been going on since 2008 each year. And each year, as Beth mentioned, it's become bigger and bigger. And we've targeted our traditional audiences, the general public and providers, but also hospital administrators, global interest groups, and policymakers, among others. And here are just a list of some of our partners, our governmental agencies. We work with our state health departments, our federal partners. FDA has been a long-term partner of ours. And internationally, we're now working very closely with the European Center for Disease Prevention and Control, as well as the WHO. And there's a number of different partners listed there, but I would say that we've pretty much tried to reach every stakeholder involved in this problem in order to get the messages out. And here are some additional examples. These are not necessarily tied to Get Smart About Antibiotics Week, but I wanted to provide some additional examples of what we do with our partners. And here's an important example. We've partnered with the Veterans Health Administration to explore appropriate prescribing in outpatient clinics across the VA system. And then we've worked with them to actually try to develop interventions using clinical decision support for providers to make the right decisions at the time that they're prescribing. And then there are other examples like the American Academy of Pediatrics. They worked with us to release an updated principles for judicious prescribing in pediatrics for upper respiratory infections in 2013. And this is really I would say a document that takes all of the existing guidelines and then applies principles of antibiotic stewardship to it. And then we were able to disseminate that in collaboration with that society. There are other examples on this slide, but I'm happy to talk to you more about those in the Q&A session if you're interested. And as Beth mentioned, this is the foundation of any effort to improve antibiotic use. Is really measuring antibiotic use. And we've done a lot of work here in this space dating back to the 1990s and actually the late 1980s. More recently, we've been working with the list of data sets that are here on this slide. We have a number of CDC surveys that we work with. One's called the National Ambulatory Medical Care Survey. Another, the National Hospital Ambulatory Medical Care Survey. And these surveys actually provide information about the volume of antibiotic use, but also give us information about appropriateness because we have both the actual diagnosis and we have the actual drug that is being prescribed for that diagnosis. So that's a very powerful survey that gives us a lot of important information. We've also worked with proprietary data from a vendor that maybe you've heard of, IMS Health, and they collect pharmaceutical marketing data and allows us to look very granularly at prescribing at various levels at the county and state, and I will show you some of the results from some of those analyses in just a moment. We've also looked at antibiotic expenditures, and then again, my second bullet there is based upon the population-based prescribing when we're looking at prescriptions filled by state or county. Qualitative research has played a very important role in our program activities for many years. In order to really tailor our messages for our intended audiences, we need to get feedback from the people who we're trying to reach. And so we have done a number of qualitative research studies over the years in order to develop our materials and make sure that our messages are resonating with our audiences. Now, I just want to share this slide because it really identifies, where some of the problems are in outpatient human healthcare in terms of antibiotic overuse. And these are the 5 conditions that we've been targeting for many years in our attempt to improve antibiotic use. And what I would say is, if you're looking at this very closely, you'll see that there's data from 1995 and 96, that red bar. And then another bar is the khaki bar, 2005 and 6. And if you compare those bars, you see that we have made some incremental improvements in prescribing for these conditions. And I want to point out that colds and bronchitis are conditions for which antibiotics are never indicated. And so this is just an indication of how much more work we have to do. And I would say that we have continued to make progress since 2005 and 6, but there is still a lot of inappropriate antibiotic use for these conditions in ambulatory care. And again, I want to make the point that this is where we're focusing. We don't want to just blindly reduce antibiotic overuse. We don't want to just say we need to reduce antibiotic use and not have a specific target, because clearly we want to do this in order to improve healthcare and not jeopardize the health and the management of infections for our patients. Okay. Very briefly, we've been able to look at cost as well and the breakdown and how that looks across the different healthcare segments. And we looked at the community, hospitals, and nursing homes. And that largest piece of the pie is the community setting. $6.5 billion are spent in the community setting on antibiotics each year. And if you think about this, the antibiotics prescribed in ambulatory care are actually quite inexpensive. So this doesn't really represent actual use. If you were to convert this over to actual use, about 80% of that pie would be community setting antibiotic use. So this is really helpful just in terms of thinking about, okay, well, where do we have opportunities to make improvements? This is the other data set I talked about, the proprietary data set from IMS Health that represents all outpatient antibiotic prescriptions. And this is data from 2011. And we're able to basically put a total number on the volume of antibiotic prescriptions in the U.S. each year. And that's very powerful. We were able to come out and say there are 842 prescriptions per 1,000 persons in the community each year, and that's enough for 5 out of every 6 people. So I think we don't want this to be buried by the fact that there is a lot of antibiotic use in agriculture. We want this to be recognized. There is a lot of antibiotic use in humans in the community as well. And you can see here just by the distribution of this chart that the most antibiotic use is used in the youngest and the oldest age groups. Now, this is where it really got interesting. And somebody just asked this question about, okay, well, what are we learning about variation in geographic antibiotic use? And this is a slide that shows us what it looks like by state. And so we have antibiotic prescriptions per 1,000 persons by state. This is 2011 data, but I can tell you I've looked at more recent data, and it looks exactly like this. And our highest prescribing state is Kentucky. They had 1,281 prescriptions per 1,000 persons. Compare that to Alaska, where there were 348 prescriptions per 1,000 persons. And if you just put the South all together and that Appalachian region all together and compare them to the Pacific Northwest, their prescribing rates are more than double the Pacific Northwest. So it gives us an idea of where we may need to intensify our efforts in terms of improving antibiotic use. Now, the questions about why this is happening and the answers to that question are quite complicated, actually, but I'm happy to talk more about that if you're interested. Okay, so I will finish off by saying that we've learned a lot from these 2 decades of appropriate antibiotic use activities. And as Beth had mentioned earlier and we just spoke about, measurement is extremely important. And we need measurement to really guide us in terms of where we should be focusing our interventions. We need measurement to tell us how we're doing and what progress we're making. And so we start with measurement of antibiotic use and research, or, I consider this data for action. And then we identify where we need to take action. And based upon that, we're able to develop messages for our target audiences. And in this case, and I mentioned earlier on, we focus heavily on acute respiratory tract infections. Some new messaging we're planning to incorporate has to do with incorporating the concepts of what can happen if you take an antibiotic when it's not needed, and you could develop an adverse event like Clostridium difficile colitis. So that has to factor into our messaging, in addition to the concerns around antibiotic resistance. We also have really worked to develop a robust partnership network and leverage the support of those partners in order to get our messages out, but also to help us with our interventions. And then we support local level intervention programs, and I didn't really get a chance to mention this, but we have 15 funded state health department programs and activities, and through that we're able to do local level interventions, and many of those states have provided us with information that can be useful for implementing programs in other states, especially in those high prescribing states that we're seeing on that map. And again, I didn't really talk very much about developing national policies, but we could talk a little bit about this if there's time. We've also worked to develop what we call quality measures for improving antibiotic use in outpatient settings in collaboration with a number of quality measures organizations. And so that allows individual providers to really undergo tracking, and the health plans and payers and health systems can use those data to say, okay, well, this is an outlier. This prescriber is prescribing almost every time for bronchitis. And this person's doing a lot better. Why is it so different? They work in the same practice, and they can use that information for leverage to educate one another. Okay, lastly, as you saw on my chart about antibiotic use for the respiratory infections, we have made some progress, which is wonderful, and we're very excited about that progress. But recognize that we've been doing this for now 2 decades, and that was the first 10 years, so there's been a little bit more progress since then. But the point I want to make is that changing behavior and culture takes time. And in fact, we were at a meeting last week with colleagues from Pew Charitable Trust, and someone in the room said, you know, this is not the long throw in football. You're not going to throw that ball and make a touchdown. This is one of these situations where you're going to be on the ground, you're going to be making those short little passes, it's the rushing, you're working on 2 and 3 yards at a time. And that's kind of what this really is all about. It's about incremental progress because, again, changing behavior does not happen overnight.